let's call them interesting times, we're grateful for the opportunity to invite virtual audiences to come together to share ideas and creativity, even when we're not exactly, coming together. And so I'd especially like to thank Dr. Lee for helping us keep the conversation aloft here in Seattle. Tonight's presentation will run 30 plus minutes, followed by a question and answer session. The program can be viewed tonight in its native habitat on Crowdcast, as well as our Facebook and YouTube pages. To watch with closed captioning, head over to YouTube, where you can enable real-time captions by clicking the CC button in the bottom right corner of the video player. Video will also be available for rewatching immediately following tonight's broadcast. I should also note that if you have questions, please try to submit them using the Ask a Question button on Crowdcast. And although we cannot guarantee we'll be able to address every one, we'll try to get to as many as possible. Town Hall is adding new events and podcasts every day. Upcoming programs include Attorney General Bob Ferguson, Tom Mueller, and Tom Carpenter discussing the essential role that whistleblowers have played in ensuring any kind of safety at the Hanford nuclear site. Aaron Bobrow Strain on the experience of undocumented immigrants. Stephanie Kelton on the myth of deficits and an economy for working people. And another installment of our new Saturday night tradition, Earshot Jazz, live at the Forum. Meanwhile, you'll also find many past events available in our digital media library. It's kind of a memory hole for the way life used to be, February. Town Hall's work is made possible through the support of our sponsors. Civics at Town Hall in particular is supported by the Real Networks Foundation, the True Brown Foundation, KUOW, and the Wincote Foundation Northwest. But as most of you know, Town Hall is fundamentally a member-supported organization, and I want to thank all of our members watching tonight. On that note, Town Hall and nonprofits at large are under significant strain with the recent wave of event cancellations. We hope you will consider extending your generosity by supporting us during this difficult time through a donation on the donate button at the bottom of your screen or by becoming a member. And our partner booksellers, as you might imagine, are reeling right now as well. Since you're certainly going to be interested in going deeper on the subject of tonight's talk, please use the link on this live stream page to purchase your copy of The Long Fix through Third Place Books. All right, then. Dr. Vivian S. Lee, MD, PhD, MBA, has been a practicing physician, scientist, and healthcare administrator for over 2 decades. Among her leadership roles in academic medicine, Dr. Lee has served as the inaugural Chief Scientific Officer and Vice Dean for Science at NYU's Langone Medical Center. Prior to that, she was the Vice Chair for Research in the Department of Radiology there. For 6 years, she served as the CEO of University of Utah Health and the Dean of the University of Utah School of Medicine, among other roles in Salt Lake City. During her tenure there, she was elected to the Association of American Medical Colleges Council of Deans Administrative Board. She's also a member of the advisory boards of Massachusetts General Hospital and the University of Pittsburgh School of Medicine, and her writing has appeared in the New England Journal of Medicine, the Harvard Business Review, the Journal of the Association of American Medical Colleges, and other publications. Speaking of other publications, Lee's first book was an academic page-turner on cardiovascular MRIs, and apparently, I'm told, not for the faint of heart. And I need to say something. In the 15 years I've been on this job, that is the first intentionally terrible joke I've ever told in an introduction. That doesn't mean there haven't been terrible jokes, believe me. At any rate, her latest book, and the thing blessedly that's brought us together tonight, is The Long Fix, Solving America's Healthcare Crisis with Strategies that work for everyone. Please join me in welcoming Dr. Vivian Lee.
Thanks so much, Ware. It's really wonderful to be with you tonight, and I'm just thrilled to be part of this event and really looking forward to a healthy and hearty set of discussions. And I also want to acknowledge that we are living in some very complicated, complex times, and I just want to thank you all for joining this event tonight. I'm planning on speaking for about 30 minutes or so and then welcome your questions. And so for this time of prepared remarks, what I thought I would talk about would be maybe a series of 3 questions. First, why I wrote this book. And then I thought I would talk about how it's structured and the main premise of the book. And then of the 12 chapters, I thought I might dive more deeply into 2 or 3 topics, depending on how much time we have. So let me start with why did I write this book? So I wrote The Long Fix. It has its origins in a series of presentations that I made to our brand new medical students when I was the dean of the medical school at the University of Utah. And these first-year medical students were fresh out of college, new to medicine, relatively new to healthcare. And I really wanted to share with them what I wish I had known before I had gotten into healthcare, wanted to answer the questions they had about how healthcare really works, and in particular to prepare them for how they could really make a difference in the field beyond the practice of medicine, actually the experience of working within healthcare itself. And many of the questions that I wanted to answer were the same questions that I got when I joined Verily, where I now work, which is Alphabet's healthcare company, and where I have met a number of really talented, bright engineers, product managers, user experience researchers, and the like. And they also were all trying to understand just how this very complex system we call healthcare works and how they can make a difference. I think that we all know in the news or from our own personal experiences that there are many, many components of healthcare that feel broken. We know about the rising cost of medications, balance billing or surprise billing, the lack of insurance for so many Americans in this country. But what we haven't heard so much about are the solutions. And as I have worked in healthcare for over 2 decades and traveled around the country and even around the world learning from others, I wanted to have the chance to share some of the stories of where new and different ways of providing healthcare and paying for healthcare are working really successfully. And in sharing those success stories and those bright lights, I found that I was able to weave together those narratives and reached an increasingly clear sense of how we can extend those local solutions into a national strategy for healthcare. And so that's really why I wrote the book, The Long Fix. I wanted to write an optimistic book that actually offered solutions, which is, I think, something that we very desperately need. And it was called The Long Fix because of a conversation that I had with Mike Leavitt, who was a former Secretary of Health and Human Services and former governor of Utah, who was really reflecting on the fact that he felt that the trajectory of changes in healthcare took maybe 30 or 40 years at a time. And he was, in our conversation, we felt that we might be in the middle of one of these cycles of, say, 35 or 40 years. Since the COVID pandemic, I'm actually feeling there's a much greater sense of urgency about tackling some of these problems. And so I'm hopeful that the long fix might be a not so long or maybe slightly quicker fix. I'm optimistic about that. So let me now turn very briefly to how the book is structured and what I talk about in the long fix. So I start by laying out the fundamental premise of the book, which is that the central problem in healthcare is really not so much about the delivery of healthcare, but really about how we pay for it. It's really the economic or business model of healthcare. And if I were to prioritize, if there were just one thing that I would say we need to really focus on, it's on really changing that economic or business model. And that it's not so much who is paying for the healthcare, and we can talk a little bit more about that if folks are interested in the Q&A. So a lot of the discussions about should we have Medicare for all, for example, I don't believe that it is much about who is paying for it, although of course at an individual level it does matter tremendously. But from a policy perspective, I think it's really more important for us to solve what it is that we're paying for in healthcare. And specifically what I mean by that is really how our healthcare system is really focused on paying for action, paying for procedures, what we call a fee-for-service healthcare system, whereas paying for better health would create a completely different set of incentives in healthcare. And if we did that, and I will talk about some examples of where that actually is happening in our country today, we would find ourselves investing far, far more in prevention and in primary care. It would incentivize hospitals and physicians to work together instead of in conflict as mortal enemies, as I'll talk about a little bit as well. And again, examples of this are already happening in the country where we have systems where we are paying for health, paying for better outcomes. So that's really what I talk about in the first section of the book. In the second section, I look specifically how the healthcare industry itself would act very differently in this model, where it was motivated, like almost any other industry in this country, to actually compete on better health, compete on delivering value to patients, to its customers, I should say, instead of just simply doing more and more procedures to them as we have in our current system. And so in this second section of the book, I start with safety and talk a little bit about how hospitals can learn from other industries, ranging from airbag manufacturing plants to the aviation industry, for example, to make healthcare safer. I talk about the critical role that doctors play in how our healthcare system works, and how with the right incentives, their type A, very intrinsically motivated personalities can and are tapped to really improve quality and even reduce the cost of care. And finally, if the business of healthcare changed, patients might actually move into the center of the universe of the healthcare business, because their health would be paramount. Their health would be driving the business model of healthcare, instead of the way it is today, which is really where physicians tend to be the center of the universe in healthcare, because the physicians are the ones who generate all the action, who generate all the fees in a fee-for-service world. In the next section, I dig more deeply into two health industries, the pharmaceutical industry and the data and technology sectors, and tell stories and reflect on what they could be doing differently if they were competing to make people healthier at lower costs. And then finally, I focus on systems that actually provide big picture views of how our healthcare system could work completely differently, taking the perspective of the two biggest payers of healthcare in our country, employers, who foot the healthcare bills for about half of all Americans, and the government. But in this case, instead of talking about, say, Medicare or Medicaid, I actually talk about the military health system and the VA, and use those systems to shed light on how government-run healthcare could actually pay for better health outcomes and actually produce better results at lower costs. And then finally, I close in a chapter that really summarizes the action plan for the long fix. And in each chapter, each chapter is filled with stories, with narratives, with examples, and each chapter ends with an action plan for what individuals can do, for what physicians can do, employers, payers, and policymakers. So that's essentially the structure of the book and the content of it. So now let me just transition into a couple of ideas that are in the book, and see how much time we have, and I'll talk through 2 or 3 ideas. So let me start with the one idea, the one big thing. And actually, in the course of researching this book, I interviewed over 100 different people in healthcare, physicians, pharmacists, insurance executives, patient advocates, community workers. And I asked them, what's the one thing you could change in healthcare if you could wave your magic wand? And over 2/3 of them said the same thing. And they said what I also believe, which is they would change the business model of healthcare. Our current model, we refer to as a fee-for-service model, or what I refer to in the book as paying for action. In our current model, healthcare providers, physicians, and hospitals, for example, are paid for doing things to people: laboratory testing, imaging studies, operations, procedures, infusions, regardless of whether it improves health. And so as a result, the health systems and physicians are really incentivized to do more and more things to people. And in fact, to document that they are doing more and more things to people so that they can charge and bill insurance for them. And instead, really, we should be expecting, as consumers or as individuals, to really only pay for care when it improves health or when it's likely to improve health. And even if that means not doing much of anything, that's really ideally how we should be thinking about the healthcare system, is whether it's actually delivering better health. But if you have a fee-for-service system, as we do predominantly now, and when I say that, I mean that private insurers pay in a fee-for-service basis. The government also is predominantly paying in a fee-for-service basis, although that is starting to change. It is still, Medicare is still predominantly a fee-for-service system. And what that means is that our healthcare systems invest in things that generate fees, like imaging centers, like surgery centers, like cancer centers. And we really don't invest in the things that we see right now during this COVID pandemic are absolutely essential, which are public health and primary care, because public health really doesn't generate any fees. And so if we're wondering why our COVID response has been so lame when we have some of the best healthcare facilities in the world, it's because we simply haven't invested in the things that don't generate fees. We have not invested in a public health infrastructure in this country. Even though the plans have been laid out for that, we haven't managed to do that. And so we have a $3.5 trillion healthcare system that is focused on making itself a $4 or $5 trillion business. And the only way to do that is just simply to do more things to people. Now, I will stop and say that I believe that most physicians and most clinicians are really trying to do good. They are trying to practice the best healthcare that they can, but we just have to acknowledge that the economics are such that they are incentivized to err on the side of over-treating or over-diagnosing. And our medical legal system only further supports that, or maybe even incentivizes that. So what happens in this healthcare system is you have hospitals and doctors who are incentivized to do more and more to people. And so for the people paying the bills, the payers, the insurance companies, the government, the only way to limit that spending and that perceived overdoing is to place barriers. So for the insurance companies, that means denials. That means saying that if a doctor recommends, say, an MRI, I'm an MRI radiologist, so I use that as an example. If the physician is recommending an MRI, the only way the insurance company can kind of manage its cost is to say, deny it, say, nope, I don't think that that's authorized, or I don't think that's necessary. Or they put into barriers things like what's called prior authorization, which just simply means amount of paperwork that the physician has to complete in order for that study to be done and paid for. And so it's just really a barrier that's put in. And what it does is it generates an enormous amount of work. So you have doctors and hospitals billing, insurers and payers denying and putting in more and more barriers, and they're sort of fighting back and forth. It's like what I call a $1 trillion tug of war. And at the end of the day, generates enormous administrative waste. In the US, we spend about 8% of our healthcare dollar on administration, whereas most of our European counterparts only spend 3%, 8% versus 3%. That is a huge amount of waste. And then when we can't resolve this dispute, what happens is we have balance billing. So the money that isn't paid for falls to the individual, the patient, and that's what we call balance billing or surprise billing. So that's how our current system works. And it, as you can imagine, also generates an enormous amount of other kinds of waste in the system, so much so that today, approximately 25 to 30% of all healthcare in this country, again, around $3.5 trillion, is considered waste. So when we have discussions about how can we extend healthcare to all of those who are underinsured and uninsured, there are clearly opportunities in terms of being able to recover some of the waste and redistributing that to be able to cover health insurance for more people, for everyone. Now, the implications of having this completely backwards business model of fee-for-service, what I call flying into the headwinds of capitalism, is that instead of competition and innovation working towards a better healthcare system, our capitalistic tendencies are really focused much more on doing more and more, even if it's wasteful. So what we really need to do is to think about how we can evolve our healthcare system into a model where we have actually the tailwinds of capitalism driving us forward. And of course, many of us within healthcare and in the government have been thinking about this for a while. And one example of success is in a pilot project, or what started as a pilot project and is now expanded in Medicare Advantage. So most of us are aware that Medicare is the health system for seniors in this country. And Medicare Advantage is a subset of Medicare. It covers about a third of all Medicare patients. And then within the Medicare Advantage program, there's a special model where the government actually contracts with medical groups and says to these medical groups, we're going to pay you a little bit differently. Instead of paying you in a fee-for-service way, where you just need to keep seeing patient after patient after patient in order to get paid, we're actually going to give you a fixed amount of money to care for all the patients in your practice for that year. And that fixed amount of money is going to depend on how sick those patients are. So if they're complex patients with many medical conditions, we'll pay you more. If they're generally pretty healthy, we'll pay you a little less. But we will give you that fixed amount of money. And then it's really up to you how to spend those dollars to keep those patients healthy. And we're going to track, the government says we're going to track how healthy you're able to keep the patients. You have to keep them healthy, otherwise there are penalties. And you also have to keep them satisfied, because these Medicare patients can take their business elsewhere next year if they're dissatisfied with you. So what has happened in these Medicare Advantage programs, these special programs that include groups like ChenMed in Miami, and they've now expanded to about 70 clinics across the country, CareMore, Leon Health, Iora Health, there's many of these now across the country, is that we find that these physicians, when they're given the latitude, when they have a fixed amount of money to keep people healthy, they start to practice in completely different ways from traditional Medicare clinics. Because what happens is, if they are able to keep people healthy and they spend less than Medicare gave them for that year, they actually will net that profit. And if they end up not keeping the patient healthy and having the patient go into the hospital and the emergency room multiple times, then they lose money, and it's actually their money. They will actually, they can actually go into a deficit from doing that. So what happens in these practices, and I talk about ChenMed and I talk about Iora Health in the book, but there are many other wonderful examples across the country, is that the doctors spend, first of all, they spend a lot more time with the patients. They know that these seniors, often who have multiple medical conditions, need quality time with the clinician. So instead of 8 to 10 minute visits, they spend 30 minutes to an hour with each patient. They have on-site pharmacy. They have shuttle services. They offer Tai Chi and yoga classes as part of their falls prevention program. And they, in the long run, while they spend a lot more money and more time up front, they see more than enough savings to make up for that in reduced hospitalizations. And of course, they're keeping their seniors healthy. These Medicare Advantage models are incredibly promising in our pre-COVID era. And actually, they're some of the most resilient systems because they have a set amount of money. They are paid every month regardless of what's happening. They've actually been able to stay open and functioning during this COVID crisis, while so many of our other fee-for-service clinics have had to furlough, lay off doctors and nurses. So that's an example of a new model, a relatively new model, a successful model. And when I talk to seniors and others, including family members, I really recommend that they look for clinics that offer these kind of services. The second topic that I wanted to talk about, which I haven't really been speaking about much as I've been talking about the book, is a very important theme to me, which is really the issue of safety in healthcare. And it may be surprising to you. Right now, we've been hearing a lot about the struggles of hospitals financially with the empty wards, relatively empty wards and clinics, aside from the COVID patients. But even when these hospitals are full, aside from COVID, aside from infectious disease issues, it may surprise you to hear that they aren't always the safest places to be. About 20 years ago, the Institute of Medicine, which is now called the National Academy of Medicine, but one of the most heralded organizations in this country and one that I feel very proud to be a member of, about 20 years ago, they put forward a report called to err is human. And they estimated at the time, this is 20 years ago, that about 100,000 Americans each year were dying from medical mistakes. 100,000. And if you've been keeping up with the news, you'll know that in America, we just crossed 100,000 lives lost to COVID this year. It's a devastating loss. But every year, the National Academy was estimating that 100,000 Americans were dying from medical mistakes. And since then, those estimates have actually been revised upward because, as you can imagine, if you do a death certificate research project, nobody writes medical mistakes on the death certificate. So they're difficult to really uncover. And so new research is actually suggesting that between 250,000 and 440,000 people each year are dying from medical mistakes in this country. And that would make it the third leading cause of death behind cardiovascular diseases and cancer. If you're like me, these statistics are really shocking because when you think about hospitals, you think about places that are sterile, that are clean, that are organized, and they're places that you go to heal. And so in this chapter, I talk a little bit about how some of those mistakes arise and what we could do to really address some of them. One of the most common causes of mistakes is actually medication errors. Some research actually has estimated that every time a hospital administers a medication, there's about a 20 to 25% chance of at least one clinical error. Sometimes it's a relatively minor error, so the medication was given, say, more or less than 30 minutes around when it was supposed to be administered. It probably makes it less effective, but probably not devastating. But there are times when there are really significant and serious errors. One of those cases is really because the names of many of these medications can be very confusing. So, for example, there are 3 medications. One is called Celebrex. It's an arthritis medicine. One is called Cerebix. It's a seizure medication. And the third is called Celexa. It's an antidepressant medicine. They sound almost the same, Celebrex, Cerebrex, and Celexa. You can imagine getting them confused. And in fact, this happens all the time. If you go online and search, you can see that the FDA and the Institute for Safe Medication Practices actually publishes online dozens of these look-alike and sound-alike names for drugs. And what they recommend, if you have multiple confusing names, is actually they recommend that we as physicians, that 3 of those letters, when we write out the prescription, that we put 3 of the letters of the name in uppercase, just so that we can differentiate them from other names. It's absolutely ridiculous. So there's a clear, obvious solution to that the FDA could actually prohibit pharmaceutical companies from making names for new drugs that sound just like others that are on the market. There's nothing about the biochemical makeup that is reflected in these brand names like Celebrex or Cerebix. So that's one reason why many medical mistakes happen. Another is interruptions and distractions. It may not surprise you to hear that distractions interfere with performance. And in the book, I talk about a rather tragic story of a nurse who was caring for a patient actually in Seattle Children's Hospital. On average, nurses are disrupted during medication rounds about once every 2 to 5 minutes. Emergency room doctors are interrupted about every 6 minutes on average in some studies. And it's a stressful environment already to begin with. There are many things that are going on. And so I talk about some examples of how systems have really adopted best practices from other industries, like the aviation industry, who faced the same problem decades ago and created rules in the cockpit of no chatting, no distractions, and then checklists. And the implementation of some of these practices in the healthcare environment are certainly improving practice and reducing mistakes, especially in the operating room. Atul Gawande wrote an excellent book called The Checklist Manifesto that really describes some of those practices. And then finally, the third area of medical error or related issues really comes that I mentioned, or the third, I guess I should say, perspective about it is really malpractice and the risk of malpractice. And the fact that many of the fears that are associated with some of these medical mistakes do lead to the over-testing and maybe overly cautious approach to healthcare, such that about 30% of all lab tests and up to as many as 50% of radiological studies have been considered potentially unnecessary and just reflecting defensive spending. And so I talk a little bit about no-fault insurance models, which I think are really interesting. Started in New Zealand and Scandinavian countries, where if something bad does happen to patients, they can file claims, and essentially there's a government fund or a pooled set of funds that are used to pay to cover those costs. And you don't even have to show negligence, actually, for these families to be able to collect funding. And it does not mean that there's no accountability. And interestingly, many people aren't aware that in the US, we actually have two states, Virginia and Florida, where they actually have no-fault insurance plans, no-fault models. They're not really insurance plans. They're no-fault models for babies who suffer neurologic injuries at birth. And they have shown that there are comparable payouts for the families, but no legal fees, so considerable savings to society. So I've just about, I think, run to the 30-minute mark. I think I have maybe about 3 or 4 more minutes left. So let me just fit in very briefly a third topic that I'd like to share from the book. And this is really a topic about individuals and how we can contribute to the long fix, and how we, in looking after our own health and after the health of our family members, can be part of making our healthcare system more effective, better for us, and also more cost effective. The idea here that I want to share is this notion of co-producing health, co-production or co-producing health. For many of us who have lived our lives in the healthcare profession, myself as the CEO of a healthcare system, as a practicing physician, as an educator, we think about healthcare as what happens within the 4 walls of the hospitals and clinics. But in fact, most of us as individuals know, and we teach this in medical school as well, that the vast majority of your overall health is really determined by what you do outside of the hospitals and clinics. It's really based on what you eat, how you sleep, how you exercise, what you inhale. And those, of course, are very much in each of our own individual control. And this idea of how health systems and individuals work together to co-produce health, or this term co-production, actually comes from an economist at Stanford, Victor Fuchs, who wrote a paper actually in the late 1950s about the economy, the transformation of the US economy from a manufacturing or industrial economy to a services economy. And in his paper, he talks about how in an industrial economy or manufacturing economy, the suppliers tend to produce their goods, like a pair of jeans, a car, some kind of item, and then they sell it to the customer, and they just basically hand it over to the customer, and the customer uses it. In services economies, it's really much more about a co-production, and some of the examples that people use include public services like public safety. We don't just rely on the police to provide public safety. This is a bit of a tricky issue to discuss today, so maybe I should use a different example. Let's say education. So we don't just rely on schools to provide education for our kids. We participate in the PTA, we help our kids with homework, and so we co-produce education. In healthcare, we've often been thinking about it as if it were a good, as if the doctors deliver better health to patients. But in fact, really, it's about co-producing health. And an example of how we can start to use this mindset or this framework for thinking about better healthcare, particularly in the use of technologies, comes from one case study that I talk about is in its application to caring for people who have type 2 diabetes. Type 2 diabetes is one of the most common chronic conditions in this country, and can be mostly managed, it turns out, in the home setting. As you know, with type 2 diabetes, the primary interest is for people to be able to manage their blood sugars, and if they can manage the blood sugars well, they can live long and productive lives. It is a risk factor for diseases like COVID, so it's ever more important for diabetic patients to be able to manage their blood sugars for better health overall. Our company, Verily, actually has a product called Onduo, and I will describe this product because it's one that I know better than others, but I will say that there are other products like it on the market. And it consists of a combination of technology as well as, I think, really insight into patient psychology and a technological way of co-producing health. So the technology starts with a continuous glucose monitor. It's a device the size of a key fob that goes on your arm or on your abdomen, and it basically measures your blood glucose 24/7. So instead of pricking your finger for a drop of blood to measure your blood sugar, you just put this device on, and it transmits the signal to an app on your phone where you can actually see your blood sugar tracing continuously. And the most important factor that affects your blood sugar is actually your diet. And we tend to ask diabetic patients to keep a food log, which of course they never do, because who wants to record all the food they eat? And so instead of doing that with this app, you can just take pictures of your meals and snacks. And so now you can actually make a visual association between the food you've eaten and actually see how it's impacted your blood sugars going up and down, as well as exercise and sleep, for example. If you're having trouble making that association, the artificial intelligence in the apps can make some insights for you. So for example, if I just cannot resist that fudge brownie on Wednesday evenings, the app can say, hey, you know, Vivian, I've noticed that fudge brownie, not so good. Maybe cut that piece in a half, or instead of waving its finger at me, it will just say, well, you know, if you eat that fudge brownie, this is what it did to your blood sugars the last 3 times you did that. There's also the ability to text a coach and to even do telehealth video conference with a physician, which is, of course, now increasingly important in the COVID environment, where we're nervous about going into clinics. And so the combination of having the technology and have it really being personalized to the individual enables them to really co-produce their own health, or really mostly produce their own health. It's much more cost-effective, and it can be accessible to people in urban areas or in really remote areas. And this is just one example of telemedicine and digital technologies, digital health. Other examples that I talk about include pregnant women who don't necessarily need to see a doctor in person every 2 to 4 weeks. Most of that can be done remotely. Really significant advances in mental health and depression offerings through digital health technologies. And it is one of the silver linings of COVID now that many of these technologies are starting to be covered by insurance. But I think this is an example of, again, how we can see opportunities to leverage technology to improve health outcomes and reduce the cost of care. So let me stop there. Those were just a few ideas that I wanted to share from the book, and maybe turn now to see if there are some questions that I can answer. Let's see. So I'll just read these questions aloud. So the first question is, we're currently hearing lots of stories about how bad this current pandemic is economically for hospitals. It's so strange to hear about healthcare workers being laid off or furloughed during a health crisis. Would the funding model you described do a better job of keeping the healthcare industry afloat in a pandemic like this? Absolutely. That is a really, really important and wonderful question. So, yes. So in our current fee-for-service model, really hospitals and healthcare systems are living hand to mouth. And so while some of them, not all of them, thankfully, but while some of them have their intensive care units filled with patients who have COVID, we know that their clinics and most of the other beds and wards in the hospitals have been empty for the last couple of months. And so our hospitals have, because of their fee-for-service model of care, have really been teetering for the last couple of months. And actually, I think April's data showed that almost 1.5 million healthcare workers were laid off or furloughed just in April alone. And I'm sure we'll be getting our May data soon. The systems like the Medicare Advantage programs that I described, the Chen Meds and the Iora Health, I actually followed up with them in the last few weeks to ask them how they were doing in this pandemic. And Chris Chen actually said to me, it's being paid this sort of fixed amount of money per month is almost like a subscription. It's like a gym subscription model. We get paid no matter what. And so as a result, they've been able to use some of those payments to actually make sure that they can provide care to their seniors, even while their seniors are sheltering in place. They actually set up even an urgent care facility in their clinics so that their patients could come when they needed to be seen, but know that they didn't have to go to the emergency room. That's outpatient clinics. On the hospital side, probably the best example of where this same kind of model that's more secure and less dependent on fee-for-service would be our hospitals like the military health system and the VA hospital. Those are all paid on what we call a global budget. They get paid a fixed amount of money every year to care for all the folks that are in the military health system or in the VA system. And as a result, they've also been much more resilient during this pandemic crisis. So yes, the answer to this question is moving from fee-for-service to some form, some of the different forms, some of the alternative forms of payment could definitely create a more resilient healthcare system. So thank you for that question. Okay, next question. Are there other nations that follow this fee-for-health system instead of a fee-for-service health system? Okay, that's a great question too. Yes, in fact, most of the countries that we admire the most follow more of a fee-for-health model than a fee-for-service model. So they're all different, and actually I talk a little bit about them in the last chapter of my book. Some of them are completely government run, like the NHS in the UK, where the government runs the hospitals for the most part, although they do have some private health insurance. The government pays for most of the doctors, except for a little private insurance business. And the government runs the benefit program, sort of the insurance government run program there. Others actually use a mix of private and public sector, like Switzerland, for example. But in all of those cases, there's a core offering of health that is really essentially a fee-for-health model. And that's one of the reasons why I think many of us in the US feel that we have a lot to learn from healthcare systems around the world. And while it's nice to be unique, in this particular case, I think we are spending on average about 2.5 to 3 times as much for healthcare in the US as others in Canada, in the UK, in France, Germany, even Switzerland, in Japan, and our health outcomes are far worse. So I think we have a lot to learn, and this is one of the reasons why we're very optimistic that a fee-for-health model is much better than fee-for-service. So thanks for that question. Let's see. Will this apply to a wide variety of healthcare providers? I'm looking to be a DPT and have recently discovered that many in my intended practice are moving to cash-only system. I would really like to work in a different setting than that. I know part of this is because of lobbying and validation of care type 2 insurers. Okay, so this is an interesting question. A DPT, I assume, means a physical therapist. And if I've got that wrong, write another question in. And so I guess I would say that in the Medicare Advantage models and in the models that I talk about at a hospital level system like the military health system or the VA system where they're paid a global budget or a fixed budget, it actually in those systems, it applies to all of the providers. So all of the healthcare professionals, the Medicare Advantage doctors receive the payment from Medicare and then they spend the money. Yes, doctor of physical therapy. Okay, thank you for the correct. Thank you for verifying that. So the doctors in the Medicare Advantage clinic, like ChenMed, Iora Health, they would be paying the physical therapist to try to keep them healthy, and to try to keep patients healthy, for example. And I actually love the fact that you're a physical therapist because one of the areas, one of my pet peeves, and one of the examples that I call out actually from Seattle, from the folks at the Virginia Mason Medical Center, is the work that they've been doing with employers. So as I mentioned, I have a chapter on employers. Employers pay for health for, about a half of all Americans. It's a huge part of actually employer costs. On average, each employee healthcare for each employee in America is about $15,000 per year. $15,000 per employee per year for healthcare. And one of the things that this whole group of employers in Seattle did, like Costco, Nordstrom, Starbucks, they banded together, and I tell this story in the book, they banded together to demand of Virginia Mason that Virginia Mason provide lower cost and better outcomes to their employees. They actually said, you know what, we only want what works. We want 100% satisfaction. These are the same things that they would expect to give their consumers, their customers. We want to get our employees back to work. We want you to get our employees back to work. And we want to know what it's going to cost. And we want that to be consistent. And one of the pet peeves was when our employees have back pain, unless they have neurologic symptoms, complicated back pain. But if they have relatively straightforward back pain, you know what they really ought to be doing? They ought to be getting physical therapy and not going straight to the MRI, which is what I do, and straight to the back surgery. So there's a huge role for physical therapy and allied health professionals in this paying for a health world. And so I'm glad you want to become a physical therapist. I'm excited about that. Okay, the next question is, how is a patient's level of healthiness determined in a system like Medicare Advantage? Has there been disagreement about how to judge how healthy a patient is? That is such a terrific question. So anything that involves money usually is something that is a source of dispute. So the short answer is there are disagreements about how to categorize how healthy a person is, but we have reached a standard way of calculating it, which is really around what we call in healthcare risk adjustment. There are definitely ways to do it better. There are definitely some people who may game the system just a little bit, and of course Medicare tries to prevent that from happening. But we do have ways of estimating it based on the patient's diagnoses, how many diagnoses they have, and other measures, basically based on their medical records. So thanks for that question. Okay, how do we empower people to be healthy and not depend on pills to treat them with lower healthcare cost, which would lower healthcare costs for everyone? Yes, I agree with that. And actually, this question reminds me of a point that I think it's often important to remind people about, which is that in healthcare, if we are fortunate enough to have our healthcare covered by our employers or covered by, say, the government, I think sometimes we forget and we believe that the cost of healthcare aren't really our problem. Because maybe we go and see a doctor and we have a copayment, $20, $25, or we get a prescription filled and maybe we only have a modest copayment around that, if we're lucky. But I actually like to remind people that all of us are paying for this exorbitant healthcare in this country. Again, like I said, we're spending 2.5 to 3 times as much per person for healthcare as most of our European, Canadian peers, for example, Australia and so on. And we pay for it actually in at least 3 different ways. So we do pay for it in our out-of-pocket costs, co-payments, in our deductibles, in what's called co-insurance, which is the percentage of our hospital bill, for example, that we might have to pay. And in fact, those out-of-pocket costs for employees have been inching up year by year, such that right now, employees are paying about 30% of the overall healthcare bills. So the employers are paying a smaller percentage. So we do pay out of pocket. Of course, we pay a lot in our taxes for Medicare. We see that actually in our pay stubs, but also for Medicaid and other government-run healthcare programs. But third, the most insidious way in which we pay for healthcare is that it's coming out of our wages and we don't even realize it. So if you look at the data from economists, actually it shows that in the last 50 to 60 years, for the average American, wages have essentially stayed flat, even though the American economy has grown considerably in 50 to 60 years. But instead of us seeing that in rising wages, most of the difference is actually going to cover our healthcare costs. And so instead of paying us more, employers are using their increased earnings to just simply cover our healthcare. And it's not even just our healthcare for today. One piece of data that I discovered when I was working, doing research for the long fix, was that employers are actually even taking money out of our retirement money. So what would have in the past gone to our retirement funds is actually also being used now increasingly for covering our health care today. So we are paying for it multiple times over. And empowering people to be healthy, I think that it's very important that physicians, insurance companies, hospitals, that we're all aligned around people's health being the most important thing. So in these Medicare Advantage programs that I described, those doctors want you to be as healthy as possible. So Iora Health, another one of these groups that has these Medicare Advantage contracts, their physicians spend a lot of time de-prescribing. So we hear a lot about prescribing, right? Recommending more medications and so on. It turns out about half of all Americans are on at least one medication. And of those who are on at least one medication, on average, we're on 4. So on average, the people who are on medications are prescribed at least 4 medications. And Rashika Fernandopoulos, who is the founder of Iora Health, tells me stories about how these patients will come in with literally baskets of these pill bottles. And their doctors will sit down with them because these, as you can imagine, they've gone to see different specialists. And every time they've gone to see a different specialist, they got prescribed a couple more medications. And so these Iora Health doctors actually sit down and de-prescribe because, as you know, these medications are not without side effects and they're not without cross reactions when you take them all together. So, and they're just confusing. They're just simply confusing to keep on top of. And so they de-prescribe, which in the long run can really do a lot of good for these patients and lower their healthcare costs, exactly as you point out. So And I should also mention that the kinds of digital health solutions like the virtual diabetes clinic that I described, the OnDuo clinic, is as effective in keeping people's blood sugars under control as medications. So as we can develop more technologies that can enable people to eat healthier diets, but to know what is healthy and to realize what they're eating is affecting their bodies in certain ways, and to have that information, just like they do with the blood sugars, or for example, for blood pressure, the more people can eat healthier diets and live healthier lives, also the less dependent they will be on medication. And all of that would definitely lower healthcare costs. Okay, we are almost out of time, but let's see, the last question that I will answer, which happens to be the last question up, is in the Medicare Advantage type program, how do you prevent practices from cherry picking the healthiest patients and or ones without pre-existing condition? So that is that's a very savvy, very smart question. And the truth of the matter is there are definitely stories, like in every other industry, healthcare has its own share of bad apples. I'm just going to say that that's true. And there are stories of where people put their Medicare Advantage sign-up clinics on the 3rd floor of a walk-up building. And so only those who could climb the stairs up can actually sign up. I've heard those stories. I don't actually know if they're apocryphal or they're actually true, but I've definitely heard those stories. The way Medicare Advantage works, though, now is that the earlier question that someone asked about risk adjustment is actually trying to combat this. So the government is actually probably in some ways even overpaying. I don't know if I probably shouldn't be quoted as saying that, but they're paying quite fairly or maybe even generously for patients who have multiple chronic conditions and who are more complex, just to prevent this from happening, just to prevent physicians from avoiding sick patients and preferentially trying to treat healthier patients. So that's how they're trying to do that now. And then lastly, okay, I know I was going to finish, but I love this question. So based on what you just discussed, I would say that as we had a home ec class in the past, which some would like to have again, we should have a comprehensive nutrition and lifestyle class in all public high schools. And I will end my Q&A session by saying, yes, I totally agree with that. I think we need to focus on nutrition, lifestyle, how people, actually the military's really embraced this, how people need to sleep more, exercise more, and eat healthier diets. And I could not agree with that more. So thank you very much. Thanks for all these questions, and thank you for the chance to be with you tonight. Really enjoyed it.
And on behalf of Town Hall, I just want to thank everybody for tuning in this evening. And again, thank you to Dr. Lee for this wonderful discussion. If you enjoyed this event, you can find many more just like it on our website, townhallseattle.org. We hope you'll consider making a donation to Town Hall Seattle. Your support will allow us to continue to provide events like the one that you just saw. And if you're interested in purchasing a copy of Dr. Lee's book, The Long Fix, Solving America's Healthcare Crisis with Strategies That Work for Everyone, please use the link on this live stream page to purchase through our friends at Third Place Books. And finally, thank you again for being here tonight. Have a great evening, everybody.